Welcome all to the Elusive Endometriosis and Fumbling Fibroid Series 3 today on 16 September 2020 from 6 p.m. onwards, supported by Bharat Serum and Vaccine Limited and academic partner Science Integra. This is a program for Bridging Bharat. Namaste, ladies and gentlemen, friends and colleagues. A huge vanakkam to all. While all are expecting me to start off on elusivity of endometriosis, I want to add a spiritual effect to it before I introduce our impeccable delegates. You see, it is a natural process that things flow from high to low, cold to hot, high density to vacuum, isn't it? That's why wind flows. To a certain level, it is good. Beyond control, same wind can cause damage. You see, when people enter in an empty bus, they don't sit in the same side or sit next to a stranger when the seats are vacant. So we also occupy empty spaces first, isn't it? Same thing happens to our mind. It focuses on what is available, what is short, up to certain level based in individual capacity. It is a good driver for ambition, growth, progress and development. Beyond control, it could lead to a dominant feeling of being incompetent, feeling deprived, frustrating, and will not let us enjoy, appreciate what we have or whatever achieved. Sometimes these shortages, vacuums, gaps are the key to keep us alert, aware, motivated to perform better. And that's what we intend to do. Clear the elusivity and the fumbling to perform better in this perennial times of COVID pandemic. So I welcome you all to this wonderful webinar on elusive endometriosis and fumbling fibroids. And we have with us today our chief guest, Dr. S. Shantakumari Madam. We all know, but it is my duty to introduce her. Dr. Shanta Kumari is the President-elect 2021. She is a very strong leader. I call her as the Iron Lady of India. And she is outspoken. She is very good and genuine to the heart. And we all know organizing her conferences all over India from 2010 onwards. She has got many degrees and many awards to her credit. And presently, she is on the FIGO working group on violence against women. She has got FRCOG from UK, FRCPI, ICOG secretary, initiated the DHIRA, a social medical legal campaign to eliminate violence against women. I can go on and on, but I don't want to be between you and her. I request Dr. Shanta Kumari to please inspire the audience and the delegates and the panelists and the guest of honor chairpersons to please guide us. Thank you.
Good evening, everyone. Thank you, Niranjan, for your kind words of introduction. Let me tell you, honestly, when you called me for this program, I was quite, I don't know what to say. That emotion is very difficult to explain because this is a session which has all my favorite people. Kurian Joseph sir, whom I'm very fond of, from long time, from the time I became a gynecologist, and we have got all your guests of honor, Jayam Kannan Madam, Asha Rao, then Ramani, my dear friend, and of course Palani Appan, Sampath, Krishna Kumar sir, our own Dr. Krishna Kumar sir from Mumbai. He's also from Chennai side. And Niranjan, I have to really appreciate the way you have taken over the virtual media in the times of COVID. So we have seen a different side of Niranjan. He's become the Arnab Goswami of Foxy webinar series. So we really started enjoying the webinars, and he's been quite dynamic to put this pandemic situation also to use and the way to connect to everyone. So I have to congratulate Niranjan on the excellent work done by you, not only in this virtual media, but you have been doing fantastic work in your hospital in Mumbai, where you are one of the forefront COVID warrior. I know hundreds of women are delivering in this COVID pandemic for positives under your leadership, your whole team. You're doing a great job, and I would like to congratulate you on your entry back into Foxy as the joint treasurer. So, congratulations once again, and I'm sure you are going to contribute in a very great manner to Foxy in your capacity as joint treasurer, and where you will rise up in the ladder of Foxy. We have seen that you have been focusing much on endoscopy and trying to make endoscopy easy and reachable. See, when I see Kurian Joseph sir or Krishna Kumar, all these people, and when they are performing, of course now Damodar is also there, young but a very good lap surgeon. So all of them are all doyens of laparoscopy. The people like me are very simple people who can do one maybe cesarean hysterectomy, and we do simple lap hysterectomies and all. But we are like awestruck when we see the great surgeons, and this is a mode where we see that these teachers are going to teach the gynecologists simple techniques so that we also learn the easier methods of offering these very beautiful mode of surgery to our patients. So that is the best part of this virtual media, where we have all the doyens, and of course moderated by you. And I'm sure, Niranjan, that with your endoscopy skills you will be doing very well to trying to make this topic a very simple topic. I wish you all the best in all your endeavors in all the organization. Wish you best of luck, and I'm sure that you will try to make endoscopy something which is simple, attractive, easy, so that all people will have that.
Endoscopy for all.
For all, so that it is not like that. See, we need not wait for a surgeon or somebody to do a surgery. We should be able to do our own surgeries, because we understand the importance of saving an ovary. We understand the importance of saving an uterus as gynecologists. So that is the most important crux of being an endoscopic surgeon, of a gynecologist. Anybody can be an endoscopic surgeon, but what is the use of a general surgeon coming and doing an gynec endoscopy? They don't know the importance of the uterus or the ovaries or anything, as they are only interested in their surgical skills. But we are interested in our women's health. Our gynae endoscopy is there to save the uterus, ovaries, and all for further work. And that's why we need our people like Kurian sir, Krishna Kumar sir, Niranjan, all of you, to make endoscopy easy for all the coming generation. I'm sure, Damodar, you also will learn from these doyens to teach endoscopy to your next generation younger candidates, so that they don't need to rely on anybody else. Niranjan, you should take this up. See that endoscopy is reachable to all. So thank you very much, and it's lovely to be here. And madam was who was asking me what I was doing in this South seminar. I happen to be a Chennai girl. I'm married to somebody from Chennai, and my father is from Salem, and my grandmother's from Trichy. So obviously I have to be a part of this webinar. So it's a pleasure to be here with all of you. Thank you very much.
Thank you, madam. Thank you. Wonderful. I reiterate here, we are very happy, madam, that you are representing us next year, and I hope COVID goes away. That's the reason I have called the doyens from south of India. They are not only representing South, but they have gone pan-India. And Kurian Joseph sir has gone further to 26, 28 countries and Asia, Oceania. It's a very honorable thing which we have today. Can I have the slides, please? Now I would like to call upon our guest of honor. We have with us another iron lady, Dr. Jayam Khannan. She is the Vice President of Foxy. She has her own center in Chennai and Trichy. A very good lady at heart, very nice. She has received the President Medal also for her outstanding performance in MBBS. Imagine, with winning 13 medals and prizes. That is an amazing feat, madam. Your journey just began that time, and you are destined to lead us in Foxy, and we are very proud. Your lifetime achievement is still going to be there, long time, still more to come. So thank you, madam, for joining us, and I request you to give 1 minute inspirational words to us. Kindly unmute.
Yeah. Thank you, Niranjan, for your wonderful words and making this virtual screen friendly to every one of us. And greet my President-elect, Iron Lady of India, and a lovely person whom I love a lot, and to all the other people on the floor. The subject which has been taken today is really elusive, it is enigmatic. If anyone has mastered the subject of endometriosis, that means you have mastered the whole of gynecology and endoscopy. Because it starts with as early as you are from puberty and it goes up to the whole of the reproductive life. So we are eagerly waiting to hear from Kurian, Krishna Kumar, and all the other panelists what is the post-COVID session which you are going to take up in the endoscopic procedures in endometriosis. Thank you very much.
Thank you, madam. Now I would request our next guest of honor, and that is another lady from Trichy. I would like to invite now Dr. Ramani Devi, madam. I request you to please share her screen. Dr. Ramani Devi is the National Vice President of FOXI 2020, leading us from South India in this COVID perilous times. She has got many awards. Again, 10 gold medals during UG and PG period. Oh my God, I can't believe Chennai ladies, Trichy ladies are so wonderfully intelligent. And it's amazing to see that, madam, you have even got the APJ Abdul Kalam Award 2016, recipient of Dr. Navamani Bose and Dr. Rameshwari Nallu Swami Oration, Dr. Datta's Award for the Best FOXI Focus 2016, the Best Committee Award. You are also recipient of Dr. C.L. Javeri Symposium for the year 2019, recipient of Dr. M.S. Asraf Award for the IMA Trichy Branch 2019. She is the Managing Director of Ramakrishna Medical Center LLP in Germany, Janani Trichy Fertility Center. And she is also on the International Advisory Board member of Endometriosis Society of Bangladesh. Welcome, Madam Dr. Ramani Devi. I request you to please give us 1 minute inspirational speech.
Good evening, my dear friends and colleagues. Respected Dr. Shanta, my dear friend, and moderators and chairpersons for today's program, and Dr. Jayam Kannan, who has been a guide for me for my safe travel through FOXI, and the members of Trichy OBGYN Society, Bangalore, and then Oxy Society. I think this is one of the most important webinars we should have, because as on day, if you look into the research data, the maximum number of researchers is only on endometriosis, and every day newer aspects are coming on endometriosis. And both endometriosis and fibroids are supposed to be friends for each other, but they are foes for us. So let us see how we are going to tackle this force of us in this COVID situation. And we have with us giants in this particular field, like Dr. Ramesh, Dr. Kurian Joseph, and Dr. Krishna Kumar with us, who are going to guide us how we should manage these patients in this COVID situation. And I thank Dr. Niranjan Chavan for the opportunity that has been given to me. Thank you, and I wish this webinar a grand success. Thank you.
Thank you, madam. Thank you so much. Sana, can I have the next slide now? Thank you, madam. And now I call upon Dr. Asha Rao. She is the chairperson of Endometriosis Committee. How can this program be without her? So that's the reason we have got Dr. Asha Rao representing FOXI. She has delivered the first ICSI baby of Coimbatore and the first vitrification baby of Coimbatore. Director of Rao Hospital and Care, Coimbatore. Past President of Coimbatore Obstetric and Gynecological Society, 2017 and 2019. And we cannot forget in 2019, she did the FOXI South Zone, Yuva FOXI. She was the organizing chairperson. And I have seen that crowd, I have seen that mela of scientific galore. More than 1600 to 1800 members had come and witnessed this. Madam, you are a great organizer, and that's the reason people are so affectionate to you. and they admire you with responsibility you carry us. With this, I would also like to add that you have also got the recipient of the President of India Gold Medal and Postgraduate Gynecology Medal from Stanley Medical College. Trained at London and Brussels under the world-renowned experts, I call upon Dr. Asha Rao to give her inspirational speech of 1 minute. Thank you.
Good evening and thank you, Dr. Niranjan, for those kind words. And lovely seeing all of you, the Foxy icons here, starting from Dr. Shantakumari, Jayam, Dr. Kurian, Dr. Krishna Kumar, Sampath, Charmila, everybody. Lovely seeing all of you here. Dr. Niranjan, you are becoming an inspiring, you have become already an inspiring personality of the year, the king of webinars. You are the incoming treasurer of Foxy. Now you are becoming a shining icon in the endoscopy field also. And it's very nice that ever since I took over endometriosis committee, I'm thankful to all of you for taking up the cause of endometriosis and conducting so many webinars on endometriosis. Elusive endometriosis was the word given by Dr. Alprish Gandhi, and all of you are supporting me in this cause, and thank you so much. And today we are looking forward to a very, very nice discussion and talk, and I wish you all the best in your future endeavors.
Thank you, madam. Thank you so much. Without wasting much of our time, kindly show me the PPTs, the slides. I would like to call upon the chairpersons, and we have got 3 chairpersons with us. We have Dr. S. Sampath Kumari. She is the Foxy Vice President-elect 2022, President Board of Studies OG, Tamil Nadu Dr. MGR Medical University 2015 and 19. She was the chairperson of Foxy Adolescent and Health Committee. She has also got the Best Committee Award for her activities which she has done. A lot of awards she has got. I welcome Dr. Sampath Kumari, madam. Thank you. Now I would like to also welcome our next chairperson, Dr. Jairani Kamaraj. Madam is a consultant in infertility and high-risk pregnancy at Akash Fertility Center, Hospitals, Vadapalani, Chennai. She has also got the Rajamani Janaki Raman Prize in Gynecology and Obstetrics. She is also gold medalist in MBBS in OBGYN exam, University, Dr. Anantachari Prize for being University first in medicine, again gold medal in DGO University. Madam, you have got achievements like anything, and I would like to tell you she is an endoscopist also. She is also has an OR IVF center and she has done diploma in reproductive medicine from Germany. Welcome, Dr. Jairani. I would like to welcome now our young and dynamic IAG organizer, Priya Lakshmanan. She is the director of Akash Hospital Aditya Fertility Center, MS, Obstetric and Gynac from Sri Ramchandra Medical College and Research Institute. She has done her fellowship in infertility in the 21st Century Hospital in Kiel, Germany. She has her own Foxy accredited endoscopic training center. Chairperson of Endo Live 2019. She is an executive committee member of the Tamil Nadu chapter of Images, and she has her interest in endoscopy, fertility, life member of Foxy, IMAGE, SR, Endometriosis Society of India, and URP SSI. I want also to tell her that she is trained in Strasbourg and has done the advanced training. So with this, I hand over the mic to your chairpersons, and we will start with the session of Dr. Kurian Joseph. Thank you so much.
Thank you, Dr. Niranjan. First of all, I thank Niranjan for giving us an opportunity to participate in this wonderful program. And I am really proud to introduce Dr. Kurian sir from our own place. Dr. Kurian is director of Joseph Hospital, which is 60-bedded hospital, and he is a pioneer in gynae endoscopy in India. And he has started training the doctors from 1985 itself. I also got trained under Dr. Kurian. He has trained many doctors in India and abroad. He is our Society of Obstetrics and Gynecological Society of Southern India, Chennai. He was the president in 1998 and 99. He is the president of AOFOG 2013 and 15. And he is the Foxy Vice President at 2018. He is a board of member in 2008, International Society of for Gynae Endoscopy from up to 2011 and again in 2016 and 18. He was the organizing chairperson of AICOG 2015. And now he is the chairman of Tamil Nadu chapter of IAG. Back to Dr. Kurian. Dr. Kurian is our most lovable person in Chennai. Sir, now doctor will be giving about the talk on endometriosis and fertility surgeries.
I have to add one point here,
Kurian.
Sampath.
Yes.
Dr. Kurian sir is not only loved in Chennai, is loved all over India and all over so many like Nepal, Bangkok, Malaysia, no, the Philippines. He has got a huge fan following. You should go there with him and see. You know, Philippines is. I was very lucky. I landed along with her in the airport, so you all should experience that.
Madam, I did the gynae endoscopy training under him. Now my daughter is also a follower of Dr. Kurian. So worldwide.
Yes.
Okay. Back to Dr. Kurian.
Thank you. Can you hear me?
Yes, sir.
Okay. Good evening and thanks for all the nice words you have said. I hope I can stand up to your requirements. Thank you, Dr. Shanta. Congratulations. First time I'm seeing you as President incoming of FOGSI and all the other dignitaries. Thanks, Niranjan, for the invitation. I bring you the beautiful scene from Tamil Nadu, the lovely Rameshwaram corridor, the lovely pillars, and I'm sure the number of people who haven't seen it are amazing. So if you haven't seen it, don't go abroad, go and see all these beautiful pictures. These are all pictures which I've taken myself. And today my topic is decision making at endometriosis surgery for fertility. I share with you a classic painting. Now the beauty of the painting is you can see women hold pots in different ways. One keeps it on the head, the other keeps it on the shoulder, and the other keeps it on her hip. All the way they are carrying water. The same way things happen when we treat endometriosis. We may give drugs one time, we may operate one time, we may do nothing one time. So this is what I felt is carrying the idea of decision making at endometriosis. Why do we worry about fertility and endometriosis? We all know the incidence is very high, especially in infertile women. The possibility of pregnancy in infertility women is just about 1 in maybe 10 times the possibility of in a normal woman. But despite all this, the biggest worry is in spite of all our treatment, less than 50% of them have a baby. And that's quite worrisome, whether it's IVF or wonderful endoscopic surgery. And further aggravating it is, if you have incomplete or inappropriate surgery, it will result in even more infertility. If you Google endometriosis, you will realize that endometriosis has been around for a long, long time, possibly close to 4,000 years. And one of the things which they were attributing Indian practitioners to do as early as 800 BC was they would blame the patient, saying that the patient is imagining it. Unfortunately, you find this happening even today. Patient comes with pain and you would say there's nothing and send her home. The sad scenario in endometriosis, always I like to emphasize that depending on the referral hospital or the physician, the patient will get different diagnostic tests and undergo different surgery or medical treatment or IVF or simple observation for the same treatment, for the same problem. And this happens even today. And too often the decision is made on several other factors, like if you like the GnRH, you give that, or if you like surgery, you do that, or if you like IVF, you go straight away. So today, I just like to share the dilemma of endometriosis, because the minute you talk of endometriosis, all these things fall on your head. Whether you confirm diagnosis, the extent of the disease, whether it's unilateral or bilateral, do I use medicines? We decide everything on the age and the marital status of the patient. We decide whether we want to operate. If we operate, how or when. We decide on surgical problems we are going to have while operating, or we decide on IVF. Whatever we do, remember there are complications. And pregnancy rate is low, and there is recurrent malignancy. So today I just want to share with you 4 clinical scenarios and try and discuss with you, or possibly try and confuse you further on how you would manage this. Scenario number 1, a 20-year-old unmarried girl, although I've said for fertility, remember, she is going for fertility very soon, with a 6 centimeter asymptomatic chocolate cyst. The next scenario was a 24-year-old girl who's married, symptomatic, but she does not have any relevant ultrasound findings. The third scenario is a 30-year-old with diagnosed moderate endometriosis. And the last scenario is a 38-year-old with a low AMH. She has had previous surgery for endometriosis. She's symptomatic now with a big ovarian cyst. So you can see 4 more or less classic scenarios in which I just thought we will go further and try and check into this. So the first scenario is, if you get that 20-year-old who's unmarried, I can give you straight away 4 options. You can leave her alone, or you can treat her with progesterone. You can aspirate, give her hormones to prevent the recurrence, or she can undergo laparoscopic cystectomy, and then you can try and suppress the recurrence of the cyst. All 4 perfectly acceptable because she is asymptomatic, she has the cyst. So this is the dilemma. When you have 4 choices, how do you pick one out of this? So let's go further. The diagnostic dilemma of an ovarian endometrioma is the first problem. The classical description, they say, in ultrasound, is a ground glass echogenicity with 1 to 4 locules, with papillations, with possibly detectable blood flow. So this is the classical picture which you get. But what happens if instead you have a unilocular cyst with the appearance all matching, but you have papillary projection with flow inside the papillary projection? Do you still call it endometriosis? Do you call it atypical endometriosis? Or are we worried about a malignancy here? So this is a diagnostic dilemma with which one gets landed very often. The classical picture is of a 33-year-old who had an IVF pregnancy. She came after 3 years for an FET again. Otherwise asymptomatic. CA125 normal. And ultrasound showed a chocolate cyst. You can see the cyst very clearly. About 5 centimeters. One was ready thinking in terms of IVF. But the large cyst was reanalyzed with a more detailed pelvic ultrasound. And it showed that one area at the base of the cyst had a papillary growth, and the color Doppler revealed a venous flow. A biopsy here showed an endometrioid adenocarcinoma. So this, in a nutshell, tells us the dilemma. Malignancy is missed in very, very few number of cases, but it occurs. We have associated confusing factors like a hydrosalpinx, and we need an expert sonographer. The other instances where you have confusion of diagnosis is where you have endosalpingiosis, mesothelial hyperplasia, hemosiderin deposition. Even if you have a hematosalpinx, you can get very confused. Inflammatory changes, PID again confuses. And if you take a HSG and do an ultrasound after some time, the reaction to the oil-based dye can also produce confusion. So this is a dilemma. Once you have diagnosed, why do you treat the endometrioma? All these reasons are standard. But in this 20-year-old girl, we are interested only to preserve her ovarian function. Because at the moment, she is asymptomatic. There's nothing to worry her. And this brings us to the picture. Do not operate in young asymptomatic women with endometriotic cysts. Cysts up to 3 to 4 centimeters, they've said, can be left alone. But this lady, which I put up, has a cyst 6 centimeters. Observation preserves ovarian function and sort of avoids the surgical risk. But does the size of the cyst affect future fertility? Earlier, one would think that as the cyst grew bigger, her fertility potential decreases. Also, there's a risk, as I said, we don't have a histological diagnosis, and there is a potential that the disease can get worse. When do we plan for surgery? This is sadly not described in the guidelines. So the simple thing is, if the cyst is left alone, do you think it will be toxic to the rest of the ovary? Do you think it's going to suppress the ovary? There's a very interesting article which came in the Human Reproduction saying that the endometrioma itself does not alter the ovarian function. And it showed that the endometriomas had normal ovulation from the ovaries in similar rates to the normal ovary, as against it does not sort of change because of endometriosis. But this was a story of a 20-year-old, an MBA student. She had a chocolate cyst 5 centimeters by 5 centimeters. She was given Dynogest and sent home. She took it for 3 months. This was during the lockdown period. But she had severe pain and came, and this was the picture you saw. The 5 centimeter cyst had become 6 centimeters. It had sort of got jammed in the pelvis, causing severe pain to her. But this is just to show you that just putting her on a progesterone is not going to solve the problem. It may answer in some cases, but in some cases it can get worse. So don't think that if you just give her a tablet, it will just sort of disappear like sort of a magician with a wand. So this is the completion of the surgery. You've done a cystectomy. She's has got good pain relief, and the otherwise she's comforted. So let's go to our second scenario. A 24-year-old who's symptomatic now. She's got pain, but ultrasound does not show a chocolate cyst, or she's got some adhesions and some relevant ultrasound findings. What do we do with this? Do we sort of leave her alone? Do we induce ovulation in this woman? Or do we straight away take her for IVF? Don't think I've gone crazy, because there are people doing this as a routine. This is an accepted fact where you have symptomatic condition, whether it's confirmed or not, they say they put it as endometriosis and take the patient for IVF. Otherwise, your other choice is to take for laparoscopy and decide. But whatever you do, your best option first, confirm the diagnosis. You can see there's a normal ovary, there's a large cyst on the other side, there are adhesions, and plan the surgery. The important message being, remember that the first surgery done is the best chance for pregnancy. So thinking of that, go ahead and do what's needed. If operating, be careful to dissect the endometrioma carefully. If you believe in using vasopressin, go ahead. You could use vasopressin to achieve good hemostasis, get into the correct plane of surgery. So you've injected vasopressin, shell out the endometrioma. It looks very simple at times, but remember, at times it becomes quite messy. So we're peeling out the endometrioma. And once the endometrioma is punctured, drained, you do a cystectomy, carefully peel out the cyst lining. You can remember to use as atraumatic as possible, use minimal electrosurgery as possible. At the same time, you can see you get your planes of cleavage nicely and dissect out the endometrioma correctly. So once the endometrioma has been shelled out, then you have to go and clear out the remaining areas of endometriosis. Don't think that cyst is her only cause of or her only evidence of endometriosis. Excise all the other endometriotic tissue in the pelvis, make it nice and clean, and once that is clean, then you have to take a decision whether, if it is a large cyst, reform her ovary. Don't leave the ovary flat against the pelvis, because remember, all these patients will have to think in terms of even and IVF, where oocyte pickup becomes very difficult when the ovary is sort of stuck on the pelvic side wall. So careful dissection of the endometrioma, reform the ovary, excise all evidence of endometriotic tissue, give her good pain relief. You can see in completion, there's a picture, and then go ahead for the next story. So once you do it, what is the pregnancy rate? Pregnancy rates are very impressive. Meta-analysis shows that laparoscopy nearly doubled the live birth and ongoing pregnancy rates are well improved. Pain relief also is good. Overall, there was a belief in AJOG that in symptomatic patients, benefits of surgery overcome the risk. But remember, cystectomy is not as simple as it appears. A biopsy of 70 endometriotic cysts showed that there were glands and ovarian stroma involving 10 to 90 follicles in a cyst wall for a depth of over 2 millimeters, of less than 2 millimeters. That means that much of ovarian tissue is being removed when you do your cystectomy. So injury of ovarian tissue from electrocoagulation, from severe local inflammation, also due to a sort of autoimmune reaction, can decrease the ovarian function. Also remember that coexisting cysts such as hemorrhagic corpus luteum and follicle cysts are just being removed for no reason at all. So will that so-called simple surgery push her into infertility? A question you must all ask. What is the prospective effect of endometrioma treatment on the ovarian reserve? This again has been nicely studied in human reproduction. They compared with control that baseline, women with endometrioma had straight away to start with lower AMH levels. And these were further decreased 6 months after surgery, while the antral follicular count remained unchanged. Further, the rate of decline was not related to age, not related to the laterality, that is the bilaterality of the endometrioma, not related to the cyst diameter, not related to the number of follicles removed. They've analyzed the histopathology tissue and then found it. The pre-op AMH level correlated with the rate of decline of the AMH. So you can see very often it is not your surgery which is responsible for the low AMH. But whatever it is, remember, you must measure the AMH levels pre-operatively and delay or avoid surgical excision as far as possible for fertility concerns. So this is the impact of surgery on the AMH level. So let's go to our next clinical scenario. We get slightly more complicated. You have a 38-year-old with moderate endometriosis. Now the choices become more complicated. Do we downregulate her and straight away treat infertility, or straight away take her up for IVF? Or do we clear up the endometriosis with operative laparoscopy and then take her for IVF? Or, as I said, option D, all of the above. Give the GI downregulation, do the laparoscopy, then take her for IVF. All options. So you can see our options are so many, and confusion can be there with this scenario always. So what do we end up doing? When you have bilateral ovarian endometriomas, always beware of ovarian tissue loss. One has to be careful. In this case, we always believe in using vasopressin, and you can see we inject vasopressin into the uterus. We are not injecting the vasopressin into the ovary per se. Once we inject, go into the plane of the endometrioma, puncture, drain both sides. Once we have drained the endometriomas on both sides, we lift up the endometrioma out of the pelvis on both sides again. Once it's nice and clear, you can see that the endometriomas are being lifted out. It's fairly thick endometriosis. And then get into the plane and carefully shell it out. Remember, in these cases, if in doubt, just cut, leave the cyst wall there. Don't try and peel off too much if you cannot. It's better that she has a little bit of ovary with a little bit of cyst wall rather than less ovary and no cyst wall. That means her AMH will drop even further. So you can see how you can clearly shell it out, dissect out the endometrioma, and then leave a good clean pelvis so that if possible, you try and see if she can conceive if the tubo-ovarian relationship is good, or as I gave the option, straight away take her for IVF. So these are the options available when you have extension. Finally, to the last option which you have, a 38-year-old with low AMH, previous surgery for endometriosis, She's symptomatic with a very big cyst. What do we do now? Do we do IVF straight away? I know quite a few of my friends straight away try IVF. But remember the danger of an ovarian abscess. We ourselves have drained nearly 10 ovarian abscesses after enthusiastic people have done oocyte aspiration and gone ahead, and the remaining chocolate cyst has turned into an abscess. Then the other option is do laparoscopy followed by IVF. Again, option yes, but remember your AMH as such will be even lower. The other option is, would you like to induce ovulation, aspirate the oocyte, and then do laparoscopy, remove the chocolate cyst, and do IVF? So you can see the number of options which are being thrown up to you. And these are the points at which, or the dilemmas, or as I said, the decision making one has to indulge in to go through with this laparoscopy, with the endometriosis. So all these options are available. And here I take you to a paper by our colleague Jay Prakashan from BJOG. He said very clearly that repeated or extensive ovarian surgery the detrimental effect on ovarian reserve. And this should be considered when deciding on treatment, and especially further surgery, that means second surgery. So the theoretical benefit of performing surgery to improve the pelvic anatomy and accessibility has not been supported with substantiated scientific evidence. So should we do surgery, take out the cyst and then refer her to IVF? It is question mark. So do you aspirate the oocyte, then do surgery? Again, option sounds good, not very easy. So all these are the options one is left with. So I'll take you for a typical example. Remember that if you do aggressive surgery along wrong planes, you may leave the ovary bare. And this is a big problem. Your safe will be empty. So a typical case which we had just a day or two ago, a 38-year-old with severe endometriosis, severe pain. She had previous surgery, dense adhesions, right ovary, 15 into 11 centimeters, unilocular. There's a chocolate cyst. The left ovary is reported as normal, but it's very small. AMH 0.79. Would you like to straight away induce ovulation, but a pain is a major factor. And you can see the pictures, not very nice when you go in and see. You can see inside, there is a massive chocolate cyst. She's been sitting on it and carefully taking care of it during the lockdown. It's 15 into 11 centimeters. Now, would you like to have done oocyte induction and aspiration, follicle aspiration, a situation like this? She has a left ovary, which is a small little ovary hiding below the uterus. We could have possibly aspirated, but I'm just trying to share with you the dilemma. So at the end of the surgery, this is the picture. You can see uterus, and there you see the small left ovary. There is some tissue there. I'm reasonably happy. Possibly we could send her to the IVF people. They could stimulate and possibly get some oocytes out of it. But remember, surgery is difficult surgery. Dissection is difficult, and things end up in a difficult way. So repeat surgery markedly decreases the ovarian reserve, and if infertility is a problem, plan for IVF. So now you realize why rhinos are going extinct. You realize that problems are more complicated. You realize that the problem to achieve a pregnancy in endometriosis is not easy. There are indications where surgery has to be done. That is, if severe pain is there or disease is very advanced. If there's failure of expectant or medical treatment, non-compliance, or endometriosis emergency. So there's a simple flow chart. Suspect endometriosis, assess ovarian reserve poor, straight away take her for emergency IVF. Don't spend your time doing anything else. Ovarian reserve good, you can think of laparoscopy, or you can straight away attempt pregnancy by doing controlled ovarian hyperstimulation and IUI. If it does not work out, complete surgery, ovarian suppression, and think in terms of IVF. So you can see flowcharts are good, but remember, flowcharts help us only to a certain extent. We've had a fair number of cases, fair number of success, but remember we've had a recurrence rate of about 33%. This was what we presented at FIGO, and things are quite difficult. We've had ovarian abscess, we've had bowel ureteric injuries. So the very important message is treatment decisions have to be individualized. Avoid surgery. If the patient is incompletely worked up, if you have a doubt about the cyst, don't do surgery. If there's persisting pain despite previous surgery, work her up for other causes and for women nearing menopause. Your basket of chocolate goodies will be complete only if you limit progress, if you decrease pain, and if you achieve pregnancy. I'm not going into detailed stories like endometriotic nodules and complications because they are quite large and quite troublesome, just create problems for everybody. So in conclusion, I'd like to say that the presence of endometriosis in a patient of subfertility is a dilemma. Surgery may help pregnancy but decreases her ovarian reserve. Conservative treatment may help in certain cases for pain relief and to limit the disease. But remember, active treatment for fertility is needed. And the answer lies in making individual approach based on the circumstances of each case. So I'd like to send a special message to Niranjan for all the effort taken. Thank you. Remember, whatever you do, action, reaction are equal and opposite. Thank you very much.
Thank you, sir. Fantastic. Sir has given the options for endometriosis cases from 20 to 40 years. As he told, it has to be individualized. And from his slide, the treatment should be like the tree with good mangoes. So the effort should be to preserve the fertility. Thank you, sir. Now we hand over the mic to Dr. Jayarani.
Vanakkam. Good evening to all the dignitaries of this webinar and doyens of this endoscopy. And a special thanks to Niranjan for including me in this wonderful webinar to be a part of it. And I'm very thankful. And as a fertility specialist, as Sir was talking, when an endometriosis patient comes, our only concern is her fertility, and that comes the ovarian reserve. So ovarian reserve, anything you do, you think of the ovarian reserve, how we are going to give the fertility, how we are going to give the pregnancy. This only comes in the back of mind. When you do a counseling, when you do a surgery, when you give a medical treatment, everything that is very important. So preserving an ovarian reserve is very important in every aspect. And as Sir was telling, you have to be very clear and careful about decision of the surgery. And when you are doing a surgery, how you are going to preserve the reserve for the future fertility of these women, especially the infertile women. So to talk on this, we have Dr. Krishna Kumar Sir, who will be talking to us about preserving.
Before you start the lecture, I would like to thank Dr. Kurian Joseph, and I want to ask him one question, if you permit, please. Because there is such a big fan following, sir, I want to tell you, 819 users have logged in. There are right now 4 programs going on all over India, and it is a fact to tell. At 3:45, I was in Jaipur. At 5 o'clock, I was in Noida, Delhi, TOG, and now at 6 o'clock, I come to Chennai, Trichy, Bangalore. And sir, 819 is not a joke. It is a phenomenal thing, and I want to thank you for that last slide, because I have seen that slide. Sir, I have been and I want to tell others also that I have been sitting in Sir's panel discussion for last 20 years, because I had that opportunity when he was the Foxy endoscopy chair, and he is an expert of endometriosis. For so many years, I have participated as a panelist in Sir's panel. So whenever I used to meet him at Renaissance or Leela or say Chennai or any other place, I used to silently डर के मैं जाता था, sir को पूछता था, because I was small 20 years back. I'm still small only, sir. Sir, what are the questions, sir, for tomorrow's panel? Sir, will you please tell me? Niranjan, they are very simple. Very small things are there, and it will be very easy. You don't have to worry. And this is what he used to answer me every time. Then I realized no point in asking, sir. I think I better read. And that nervousness of mine went away as I proceeded over the decades. And sir, that is the offer I made to sir, that sir, would you like to moderate? Because he last moderation he has done was at IAGE at Ahmedabad, sir. If you also recollect, and you had some 5-6 cases, we all were sitting on one side and another side, and the way you manage, sir, and you make us thought processing our, make us work our mind on that case. And there are so many differential diagnoses. I'm sorry to interrupt you, but sir, there is one question. What would be the best option for endometriosis? Would it be ablative surgery to be done, or would you like to do a cystectomy?
For treatment of endometrioma,
Yes, sir. Ovarian endometriosis.
you have to do a complete cystectomy. There's no, today there is no role for the sort of doing ablative, but I put that condition in between. Sometimes that cyst wall just does not come out.
Yes, sir. You
In which
don't get
case,
a plane.
Don't fight with it. In which case you can just do ablative treatment and come out. Because if you try and do it at that stage, you may remove half the ovary. So otherwise, cystectomy, definitely method of choice. And it can be done quite well if you are patient enough to carefully peel it. Remember 3 instruments, remember good instrument, hold the tissue well, get
Yes.
it to the plane, it comes out quite nicely. Thanks.
Yes. Thank you.
Thanks,
Thank you,
Niranjan, for those nice words.
Thank you, sir. Madam Jairani,
Yeah.
you can please continue and introduce Dr. Krishna Kumar. Thank you so much.
I have the great privilege and honor to introduce Dr. Krishna Kumar, who is the Chief Consultant of JK Women's Hospital Fortis in Kalyan, Mumbai. And he is the President-elect for IAGE 2021. And he was the Secretary General of ISAR between 2018 and 20. And he is the FOXY Recognized Centers for Infertility and Endoscopic Surgery Training Centers. And he has been a person who is looking after the fellowship for the centers to be recognized for the ICOG fellowships for the 6 months ART and endoscopic surgeries. So, sir will be enlightening us about how we are going to preserve the ovarian reserve, what as a surgeon should know when they operate an endometriosis case. Over to you, sir, for your presentation on preserving the ovarian reserve, what a surgeon should know.
Thank you, Dr. Niranjan, and thank you for including me in this wonderful webinar. And it's a real great pleasure to be with all such great leaders and women from South India, the leaders. And it's an honor for me to be following Dr. Kurian Joseph. And as you said rightly, I have been admiring him, and I envied at times that I should have the quality like him in conveying certain messages so bluntly but so subtle way also. And as you said in panel discussion, he has an amazing way of conducting, just like what Niranjan has been named as Arnab Goswami. I would say the best panel moderator in India is Dr. Kurian Joseph, and his question and handling of cases has been amazing. So today there will be some overlap of my talk with Dr. Kurian. He has conveyed and sent some real clear messages as to how and what dilemmas we face. And definitely when we come to fertility treatment, we have that always a dilemma whether to treat the fertility or pain, because it's going to be hand in hand. How soon to treat, whether should I treat by surgery first or wait for some medical treatment, any role of long-term therapy, whether we should jump for ART for all, when to treat, and the dilemma never ends. And we know that endometriosis is a Pandora's box because it is hampered very poorly by the correlation between severity of symptoms and severity of lesions. Sometimes we find the complaint is nothing, but when we go inside the abdomen, the lesions seems to be just amazing. And the severity many a times becomes apparent only at the time of surgery. And unfortunately, there is no validated classification. So comparison of results is always a big question. So the evidence is very difficult. It becomes most of the time, experience-based medicine. So today, there is always a big question. Now, there was a big article in the JMIG where the 100 years war between experts of surgical and medical treatment for symptomatic endometriosis. It was deep, as rightly pointed out by Dr. Shanta Kumari at the beginning in her talk, that operating on endometriosis, who should operate, whether an average or a regular gynecologist, whether a gynecologic endoscopic surgeon should take care. ART specialists always blame the endoscopic surgeon and say that they all just operate unnecessarily and decrease the ovarian reserve. And today we have some people who call themselves a specialist endometriosis surgeon. So for me, I would say that any gynecologist should exactly know how to preserve the reserve in the ovary. But before surgery, definitely an imaging modality, as said, is always before pre-entry safety is a good imaging. But sonography transvaginal, we know there's a level A evidence where all patients suspected to have rectovaginal endometriosis. Of course, endometrioma, as already described and shown beautifully, in some difficult cases, you have to rule out those papillary structures and detect the blood flow. MRI is a good imaging modality, but mainly for mapping of endometriosis, mainly in the rectovaginal region, deep DIE we call. Laparoscopy, though considered gold standard, but today there is a big wave to tell us that laparoscopy is not needed to diagnose endometriosis because of excellent vaginal sonography. So today laparoscopy, of course, helps in tissue diagnosis, but should be considered only when operative surgery is to be planned. But otherwise, for diagnosis, I shouldn't say I'm doing a laparoscopy. Definitely, pre-operative planning is going to be definitely by a thorough, gentle examination by the gynecologist himself to rule out all those rectovaginal nodules, to palpate the masses, and an ultrasound MRI, which already will give you all those information which I've enumerated, and definitely an ovarian reserve test. And in some selected cases with suspicious marks, do definitely the tumor markers before you embark upon a conservative surgery in a patient, especially if the patient is having a recurrence. Now, general consideration of surgery as per as the ASHRAE guidelines, definite detailed patient counseling and appropriate consent regarding all the possible risks and complication, not just the ovarian reserve, but damage to the ureter, damage to the rectum, colon, should be handled by a trained team. I wouldn't call an expert team, but a trained team who has seen many cases of endometriosis and, of course, infertility aspect of it, and handle the tissue with care, use adhesion prevention barriers, whichever you are used. And remember, as Dr. Kurian already mentioned, first surgery is the best surgery. Always remember the disadvantages to perform surgery. It has already been enumerated, though there will be some repetition. Decrease in ovarian reserve, decrease spontaneous ovulation following surgery, and decrease response to the ovarian stimulation in IVF. There are innumerable papers condemning surgeons and endoscopic surgeons to the core by the RT specialist. Now, this particular study published in Fertility Sterility is called as the error study, endometrioma related reduction in ovarian reserve. The presence of endometrioma itself reduces the ovarian reserve. Forget the surgery. So they took a group of 80 patients, 40 who went for surgery and 40 who were healthy, didn't go for surgery. You can see that the presence of AMH itself, the presence of endometrioma, the serum AMH and AFC done 6 months apart decreases. The AMH dropped drastic, about 26%. In the control group, it was only 7%. The AMH dropped from 10 to 8. So women with endometriosis experience a progressive decline in AMH level as compared to healthy women. So that itself, the presence of endometrioma itself reduces the ovarian reserve. So that is what one has to remember. And we all know that cystectomy in an endometrioma definitely reduces the chances of reducing ovarian reserve. But this study, published by Kuroda et al. In obstetric gynecology, said that the assessment of histology impact of ovarian endometrioma in laparoscopically for a routine endometrioma and for other benign cysts which are there. Definitely ovarian endometriomas have a detrimental impact on follicular reserve in younger patients. The resection rate of normal ovarian tissue in cystectomy specimen of endometriosis group was significantly higher than those in the non-endometriotic cyst group. That means the moment you are doing a cystectomy in endometrioma, this is definitely going to be more than a patient who has, say, a dermoid cyst. So what the effect of cystectomy on the AMH level? This study published by Wang et al. In Gynecological Endocrinology last year, definitely a group of 171, AMH decreased significantly in women with bilateral endometriomas. Patients who had a larger cyst than 7 centimeter, again a significant. Where you used both cystectomy and coagulation or suturing, again the drop was more significant. And they concluded that women with large bilateral stage 4 endometriosis had a significant decrease in AMH. But there was only a short-term decrease in women with single unilateral cyst, which may recover completely within a year. So that is important to understand from these studies. So what does evidence say? Dr. Kurian has already mentioned that cystectomy is preferable over drainage and ablation for avoiding recurrence and achieving spontaneous pregnancy outcome. So today there is no doubt that if you are performing surgery on an endometrioma, if the ovarian reserve is good and if the patient is having pain, do a cystectomy. It has tremendous benefits over just ablation. Why excision? Because cyst wall excision provides greater clinical improvement. Spontaneous pregnancy rates have been more. Pain have been less. Recurrence and repeat surgery chances are less, and definitely gives you something for the histopathological examination. And coagulation and laser vaporization without excision is associated with an increased risk of recurrence. This is as far as the ASRM guideline. But you have to keep the possible occult malignancy in mind, and that is where cystectomy always gives you something for biopsy and diagnosis. Now, surgical technique, of course, I don't have to enumerate, but definitely proper magnification, respect of the tissues is very important, especially when you're handling a woman at a reproductive age group. Achieve good hemostasis, avoid peritoneal desiccation, because that is going to cause a lot of adhesions. Do ovarian salpingolysis, restore the normal anatomy, and use microsurgical instrumentation. And if suture, it has to be very small, thin micro sutures. Use least energy source and ovarian suspension, as shown it here. When you have a lot of raw surface and the ovaries tends to go and stick, a temporary suspension to the anterior abdominal wall, 5 to 7 days for the epithelialization can be done, and then can be cut from here only outside, and the ovary falls back. And by the time we hope the healing is complete in the POD area, and all these criteria are respected, definitely good results as far as pregnancy rates are expected. Now, indications of endometrioma today is only large endometrioma greater than 5 centimeter, and it is one which is rapidly growing. You have suspicious features on ultrasound. You have painful symptoms attributable to the endometrioma. There is a chance of rupture in pregnancy, and occasionally, if you think the inability to access follicles is going to be very much a big consideration, because treating an ovarian abscess is a nightmare. As Dr. Kurian said, in 10 abscesses which you must try, it is not so simple like draining any other abscess. Ovarian endometrioma abscesses are tremendously difficult because of the adhesions and the peritonitis which sets in. So I'll just take you through some of the simple before we go. So these are some small endometrioma we do come across. So you will have to decide whether one has to do cystectomy or, fulguration. Definitely ovarian reserve. Now, sonography will just show you the endometrioma. Very rarely you can pick up some of these adhesions, right? On the left side, the endometrioma is otherwise innocuous looking, the tubes, everything is fine. Definitely there will be some adhesion at the uterosacral. Dissect the endometrioma before you think you have to do, but on the right side you can see the endometrioma has already started involving adhesions with the bowel, the appendix is already pulled up. So before even thinking of touching the endometrioma, you have to separate it, taking care that you're not damaging. So very less use of energy is required in these spaces. It is most of the time you will be able to dissect it off from the lateral pelvic wall by that little bit of extra traction and pressure. Open up the endometrioma. Already the endometrioma many times starts leaking from the weakest point. The drainage of the contents do not harm your pelvis. You will give a good wash. But your further action will depend on two things, whether the presence of pain and the ovarian reserve or the markers level which you have done. But make sure that the other ovary is of at least looking good size, and this simple single cyst wall many a time may be very simple to remove, but then there is a chance of removal of large amount of cyst wall. But be very sure in the plain dissection, and this is just to show you how you can first restore the normal anatomy. You can see that this part, many a time the ureter can be very closely going through that area. So one has to be very careful and judicious in usage of any energy at that stage. And as rightly pointed out by Dr. Kurian, if you are planning cystectomy, be very sure about the plane, as you can see, and use good instruments and good traction from opposite side for you to completely remove. I will come to the steps which otherwise can be done in case you are not able to remove the cyst wall completely. So this is how you do the cystectomy on the left side, but on the right side, if you have decided not to do cystectomy because of the decrease in ovarian reserve, you may just fulgurate after giving good wash exactly those areas only where it needs to be cauterized, and not the whole of this. Now, of course, you may not be lucky all the time to have such small endometrioma. You might have most of the time such kissing ovaries. Now, one is large, one is short, small. But definitely you will see that whenever you have kissing ovary, the normal your ovarian tubal anatomy is definitely distorted, because the tubes generally are pulled medially, and many a times they will be adherent to each other. And you need to separate it very carefully. On the other side, you see the large endometrioma, and of course the other side of the ovary is generally not seen, but very difficult to diagnose that also has a small amount of endometrioma. But usually endometrioma singly do not exist unless it's a external endometrioma, not an internal endometrioma. It's an internal endometrioma, not an external. And here, of course, again, you make sure that you separate it, isolate it. And in large endometrioma, I would like to drain the contents first, reduce the cyst wall, the cyst size, and then start the cystectomy if you have decided to go for cystectomy. After doing all those adhesions, which you can see on the side, that there are a lot of adhesion, even the left ovary has got an old resolving endometrioma. But make sure that you have first restored the anatomy, lifted the cyst ovary outside, and the size which is on the larger side, which is causing pain, that cyst you decide to remove. The other side cyst wall, I wouldn't remove if I'm doing a bilateral ovarian endometrioma. I would rather prefer to ablate that side and just do the cystectomy on the side which is causing more pain and which is much larger, because recurrence we want it less. So some patients who already have 1 or 2 children, you can be a little more liberal in removing, because the recurrence has to be always considered, because most of our patients do not want recurrence. Of course, post-surgery, we will have to go for some medical therapy. Now, combined treatment techniques to preserve the ovarian reserve. This 3-stage technique, combined ablation and cystectomy with vasopressin. Then there are other things which we have less experience, cystectomy with gelatin thrombin matrix seal. And now a lot of studies are coming up where no surgery, only sclerotherapy with 100 cc of ethanol injected inside the ovary under ultrasound guidance, and they have proven, and a lot of studies are coming up where they have found that the stimulation gives similar number of oocytes, or rather more oocytes, and pregnancy rates have been similar. Now, this 3-stage technique suggested by Donez et al. In way back in 1996, where drainage followed by GnRH agonist for 3 months to reduce the cyst diameter. By the time the second look laparoscopic surgery, after 3 or 4 months, the cyst would be almost 30% of the original size. So one would expect that the cyst will be much thinner or much less ovarian tissue damage. Definitely, it has more beneficial than cystectomy at the first attempt, because normal ovarian tissue is not removed. It causes less thermal damage, because after agonist depot, the bleeding will be less, and ovarian reserve is compromised much less, and AFC was much significantly higher in studies by Tasakidis and back. But the drawback is, of course, thermal damage still is at a risk, but for the time to go to IVF, there is more time wasted. But this is a good technique, especially in very vascular endometrioma or very large endometrioma. We occasionally have to resort to an agonist depot for about 2 cycles and then do the cystectomy at the third after 2 months to relieve the pain for the patient. Now, combined ablation and cystectomy. This again suggested by Dones follows the simple principle that do the cystectomy as much as possible, but when you come close to the hilum or the ligament where it is much more densely adherent, don't try to tear it off. You may just leave it and ablate it with laser. Of course, he use laser, but we can just use bipolar. And by what you do is do not remove the cyst completely and do not damage much of the ovarian reserve. Agonist was being given by Dones et al. After this partial cystectomy and ablation. Advantage being reduces the risk associated with cystectomy and recurrence, and definitely the disadvantage is you can remove healthy cortex and cause thermal damage. For both the 3-stage technique and combined ablation cystectomy, more research is needed on the potential of using laser rather than bipolar. That is what they concluded. But definitely these 2 options are good enough. Now, since vasopressin has already nicely demonstrated, helps you to reduce the blood loss and also gives you a correct cleavage. So this is a very good way of doing cystectomy. I follow one of these 3 and more commonly cystectomy with vasopressin to have a proper clean, and in a post-cystectomy the hemorrhage is less. So you don't try to coagulate, because by coagulation after a cystectomy you are reducing the ovarian reserve much more. Now, as far as the other things are concerned, I wouldn't know much as about sclerotherapy. Now, as rightly said, pointed out by Dr. and others, that severity of the disease, this was a young girl of only 22, married for just about 10 months and had severe abdominal pain throughout the month. Forget about dysmenorrhea. You can see what havoc the endometriosis has created. Now, her AMH, even at that young age of 22, was just 1. So the presence of endometrioma and endometriosis itself reduces the AMH. Can I mute? Somebody has to mute their mic. Here, of course, restoration of the anatomy before surgery is important. And on the other side, you can see the endometrioma is not at all there, but this is deep infiltrating endometriosis, where there is basically a rectovaginal nodule. The ovarian tube are more free. It is just the central part where it is involved. So injecting vasopressin and dissecting the rectovaginal area is very important. But since I'm going to be talking more on ovarian reserve, I would concentrate on the left video, where again here you have to see that you dissect the ovarian tissue from the pouch of Douglas. But here, how much to cut will be a big dilemma, because her AMH was 1, but her pain is tremendous, and you can see the pelvis. So here again, first surgery is the best surgery. So you are trying to give her the maximum relief as far as the pain is concerned. And you have to make sure that you do not cause her, to have recurrence often. You will take care of her infertility sooner. And where if you cannot separate the cyst wall, you have to do the fine dissection occasionally to be in the plane which is more right and which you think will damage the ovary much less. This is the problem in patients who are young and who have such severe form of disease. So it's always, as I said, it is identifiable only at the time of laparoscopic surgery. Now, ASRM guideline as far as endometriosis stage 3 and 4 in women, it is said that conservative surgical therapy with laparoscopy will be always beneficial, but ovarian reserve testing should be done in patients. In patients with poor ovarian reserve, fertility preservation in the form of oocyte freezing or ovarian tissue freezing may be offered, especially in those patients who want to retain their fertility potential but who are not planning immediate marriage or pregnancy. So this is a big option which is coming up, oocyte freezing. Now, lab management of deep infiltrative endometriosis. We were always thinking that patients with deep infiltrating endometriosis, one need not do surgery if they're interested in fertility. But this very good paper published in the JMIG by Gabriel Centeni said that first time surgery, even in DIE, if the patient has come to them for the first time, not only the symptoms improve, there is an improvement in sexual function, it has a positive impact on quality of life, and thereby the pregnancy rate in patients who came for the first time had a 70% pregnancy rate rather than patients who came for a repeat surgery after getting operated somewhere else. The surgery results were just 37%. So even in patients with DIE, one should encourage a proper surgery at the very first attempt, even patients who have a problem of fertility. Now, HRA guidelines, surgical treatment prior to ART, we must counsel women with before surgery that endometrioma, the risk of reduced ovarian function, and the possible loss of the ovarian tissue. So the decision to proceed with surgery should be considered carefully in women who have had previous surgery. So surgery before ART is something which we have to say, as per Dr. Kurian just mentioned about that very large 15 centimeter endometrioma, but many a time we do get patients who have bilateral endometrioma and already operated once with hydrosulfing. So what to do? They have pain. So whether to operate before or after, whether the chance of ovarian abscess you do not want. So stimulation can be done, but you can land up, and of course you need to counsel the patient. But if you have decided to operate prior to stimulation, make sure you do not do cystectomy at all. So this is just to demonstrate that how you can do a good surgery, relieve the pain, and at the same time, of course, our hydrosulfings is being taken care here. You would remove the hydrosulfings. I would just play this a little fast. And after the surgery of removing the hydrosulfings, you just drain the ovarian endometrioma and may not do any cystectomy, which we didn't do, and do only ablation, and then start on agonist depot for a month or so, and then start the stimulation. You will get excellent follicles. And as you said, we can just coagulate those areas with the hemostasis. So in these patients, do not try to do cystectomy, even if the AMH is good, because repeat surgery is going to diminish it further. So here we can just appreciate that we are just giving a wash and ablating those endometriotic spots or those bleeding spots. So before ART, no cystectomy, especially if it is bilateral, even in the presence of pain. So to conclude, hormonal therapy for suppression of ovarian function is not recommended. Stage 1 and 2 operative laparoscopy, including adhesiolysis, increases the reproductive outcome, again a level A evidence. Stage 3-4 operative laparoscopy instead of expected management gives a big chance of spontaneous pregnancy if you have restored the normal anatomy. But a balanced approach, especially in 3-4, patients who have great stage 3 and 4, you have three options available. Either you do laparoscopy for all, for IUI, 3 to 4 months attempt and followed by IVF, or if only pain is there, do laparoscopy, or if the size is more, again follow with IUF 3 months and IVF. If no pain or size less than 3 to 4 centimeter, you can straight away go for IUI followed by IVF if the woman is less than 35. But even in the absence of pain, direct IVF in patients who have stage 3 and 4 disease, but recurrent endometriosis, direct IVF unless there is severe pain, and fertility preservation should be offered in patients who have poor ovarian reserve and who are above 35, or bilateral endometrioma or recurrent. Oocyte freezing is better than ovarian tissue freezing, and IVF, ovum pickup with antibiotic prophylaxis, freeze for all, give GnRH agonist for 2 months, and then an FET will always give you good results. So thank you for a patient hearing. So don't run away from challenges which you will face in endometriosis. Think positively and think always for the benefit of the patients. You will run over them most of the time. Thank you.
Thank you, sir. Thank you for this elaborate, very important, stressing on the points of preserving the fertility, and very important, all we should note is the first surgery has to be done in a best way. That we want to make sure to all the viewers here, to make sure that when you are coming across a woman with endometriosis, give her the best surgery so that you are preserving her fertility, giving her a better pregnancy, as well as giving her a healthy baby. And also, we are really thankful for you to insisting on this ablation in case of recurrence of endometriosis with severe adhesions. That is very important one, which we should know. We should not try to go more for peeling of all the ovarian tissue. Try to go for an ablation which will conserve a better ovarian reserve. So if you have any...
Can I have a question with the legends?
Yes.
Yeah. Krishna Kumar was mentioning vasopressin intracystic. Kurian was talking about intrauterine. May I have some more clarity on this?
No, see, injecting within the ovarian cyst is always a little difficult. I mean, you wouldn't know whether you're in the right wall. Now, if you put vasopressin anywhere in the pelvis, the final hemostasis is going to definitely occur. So that is a very good way, but many a time I do inject it very superficially on the cyst. But if you can be very sure, you can inject it on the uterus also, but the volume required is a little more when you're injecting in the uterine wall. So that is, let me take about Dr. Kurian's opinion on that.
Can I have a word from Kurian?
Yeah, thanks. Either way is fine. There's no problem at all. The trouble what we had was when we were injecting in the cyst, sometimes the needle tip just goes off into the cyst.
Yeah.
So we found it quite irritating. But there is a word of caution with vasopressin. Remember, with vasopressin, sometimes everything becomes white and you will lose your planes and you may remove more ovarian tissue if you are living there. So one has to first try and identify the plane, inject vasopressin, you see the plane standing out clearly and shell out. So it's not that it's all good. There can be problems with it also, right?
There's one question. A young girl, you said the first scenario, that is like 20-year-old with severe endometriosis, severe pain, endometriomas. You had to operate on her because of a severe pain. And how long can you continue her medical treatment? Because Dyneges does not have a long safety profile beyond 5 years.
Usually, we've been using just the OC pills, Dr. Charmila.
Yes.
I use OC pills for 4 to 5 years. There's no issue at all with that.
Now that oral antagonists have come, Relugalis has been FDA approved last month.
Yeah, but all that.
Long-term usage of
long-term usage. Even Dynogest, I'm not really very impressed because some cases are responding well, some are just not responding.
Yes.
So it's not your opinion, Krishna Kumar?
Yeah, definitely. We are very happy with the traditional COCs or the combined oral contraceptive because, as you said, definitely patients' relief have been always there. We have been trying, we have been using it, and definitely most of the patients have been happy. Now, a lot of talk about Dynogest being very excellent, but it is not so. It doesn't work in all the cases. A lot of intermenstrual spotting is there, and secondly, the cost puts a lot of people away. They want to run away from it just for the cost. Those safeties, their reports there up to 64 to 70 months. But definitely we still continue to use, but now there is a lot of talk on, the oral contraceptive pills not being effective in suppressing the endometriosis, though the pain or dysmenorrhea will be less, but whether the endometriosis is decreasing, that has been proven that it may still be present in the same way or increasing. But I don't know, we have been using this for such a long term and we are all happy about it. So we will continue to use it. I think there is no doubt about it.
There's one new combination of Dyneges with ethinyl estradiol. That contraceptive pill, is that better than the traditional OC pills?
No, here that is very difficult to say because you are feeding the endometriosis with ethinyl estradiol. I don't know whether, though it is costing less, so there may be a temptation to use it, but you are adding ethinyl estradiol, which may not be good for the endometrium.
One thing, Charmila, I would like to answer you. This Dyneges, as rightly Dr. Kurian has pointed out, it works in few people. In few people, it doesn't work as long as the size of the endometrioma is concerned. But definitely, they are relieved of the pain. So probably we can initiate with Dyneges, and maybe over a period of time we can switch over to oral contraceptive pill because for the want of money. Then regarding the long-term usage, now we have got studies on Dyneges continuous usage since the FDA has approved it for more than a period of 9 years, and a lot of Japanese study, Korean study has come, and even one of our Indian, Soni Singh, who is at Ottawa University, Canada, he has been, I had a chance to interact with him. He says that he has been using the drug for more than 9 years in a single patient, But most of these patients, they are being supported by the insurance company. That is why probably they are able to use it. But as long as our Indian scenario is concerned, maybe OCPL still has got a role in management of pain management. And Dr. Krishna Kumar has rightly pointed out it reduces the pain. But whether it actually reduces the disease
Implants.
burden, that still we do not know. And probably we say that the person who uses oral contraceptive pill for the pain factor, they are likely to have this deeply infiltrative endometriosis being masked off. So that is one disadvantage with that.
But certain patients, they are still continuing at 50 years of age for me, sir. OC pills. They're very comfortable with that from the age of 30. And they don't want to switch over to any other drug. That is also there.
If they are happy with that, let them continue.
Yeah, yes, ma'am. Yes, ma'am.
Sir, thank you all of you. Wonderful time and wonderful discussion we had. And sir, Dr. Korean Joseph, sir, it was very nice presentation. Dr. Krishna Kumar, sir, I want you to be there to give your expert comments. Now I request our Foxy Endoscopy Chair, Dr. B. Ramesh, to start his panel discussion. Welcome, Dr. B. Ramesh. But before that, I would like to introduce my panelists. So I request Science Integra to show the curriculum vitae of all the dignitaries and the esteemed panelists.
Can you put back the history once again?
Yes, Dr. Ramesh, before I start, I want to introduce you. Dr. Ramesh and I, we have done post-graduation from Mumbai. Dr. B. Ramesh worked in Wadia and I worked in Sion Hospital. And one day we also met in Nepal while giving MRCOG. That's been a long journey now. And Dr. Ramesh is himself a pioneer, has owned his methods of endoscopy, has own hospital in Bangalore. He also went to Atlanta, USA. I also went to New York. And further education and studies and knowledge doesn't stop. Knowledge is infinite. And I want to tell you, he has done more than 70,000 gynae laparoscopy cases. He was the first gynecologist to use 3D laparoscopy surgery in India. Has got many articles. He has also contributed in the IAG newsletter, and was the editor, and he was so generous enough to give the energy sources chapter in that. He is also running a charitable clinic and giving free treatment to all those needy members of Santama Vahatur village for last 20 years. So that's a very noble cause he is doing. Participated in major conferences and workshops. Welcome, Dr. Ramesh. I would like to have the next slide now. I want to introduce my friend N. Palyanappan, and I met him in 1995. We have been thick friends since 1995. It's been 25 years. He's climbed a lot. Presently, he is OGSSI president. He's a man with the wonderful, colorful ties and shirt. I want to compliment him. He will be always in shirt, and he is a professor at the Sri Ramchandra Medical College and also unit head. Like me, I am very proud of him. He is also the orator of Dr. Kamini A. Rao, Yuva Foxy orator. He has got Young Gynecologist Awardee of the Asia Oceania Federation in 2007. Contributed various chapters and textbooks. And we also know that he was the Foxy chairperson of the Safe Motherhood Committee. Welcome, Dr. N. Palyanappan.
Huh?
Can I have the next?
I will follow it.
I want to welcome Dr. Charmila. She is very dynamic. She is from Trichy, was a chairperson of Clinical Research Committee. She has got the best Foxy Award for her committee work. She is also the joint treasurer of IFS. President of Menstrual Hygiene Management Consortium. She has got many trophies and awards, namely the Meru Ansotia Prize for Committee, and also has edited handbooks, ICOG Campus, and has her own multicentric mother study on ovarian reserve. Welcome, Dr. Charmila. Such a nice pleasure to meet you. And we have our young dynamic, Dr. Damodar R. Rao. He is a consultant in the Rao Hospital. He is a Tamil Nadu IAG Joint Secretary, co-convener of Special Interest Group Endoscopy, IFS, Treasurer of the Coimbatore chapter of ISAR, Organizing Secretary UA Foxy, South Zone 2019, got Best Paper Award in IAG, has done lots of workshops in hysteroscopy, laparoscopy. So let us hear from all these luminaries of southern India, and one by one we will go ahead. This is what I intend to start, and it depends how you want to build yourself in spite of these challenges which we have. So that's what I would like to welcome all these great panelists which are there. Now I call upon our Foxy Endoscopy Chair, B. Ramesh. Sir, thank you so much. Please unmute your mic, sir, and you can start reading the case and we will discuss the case. Dr. Ramesh.
Yes. Yeah, she is a 22-year-old presenting with lower abdominal pain, her periods profuse, heaviness, 3 abortions and all. I would like to know the ultrasound picture of this patient. I would further investigate and I want to know ultrasound picture of this patient.
Sir, kindly read ahead. Dr. Ramesh, please read ahead.
Yeah.
What you're cooking?
Ultrasound is normal.
Sir, she has got 3 abortions in 3 and 6 months. She has heaviness in uterine region. Yeah. And her periods were early, profuse with severe pain in the lower abdomen which goes to the back.
Pain in the, yeah, of course, for the 3 abortions showed posterior wall fibroid 4 to 6 centimeters. So obviously she needs myomectomy. Possibly myoma could be the possible reason for the abortion. That is number 1. That could be the cause of pain. Number 2, along with the myomectomy, I would like to do laparoscopic encerclage at the same time, because these are all mid-trimester abortions, and along with myomectomy, I would put a laparoscopic encerclage so that the treatment is complete for us.
Nation wants to see you, Dr. Ramesh. Please unmask. And please, I would like to request you to please give your commentary for this video which we are showing a lap myomectomy and hysteroscopy. Please go ahead.
Yeah, hysteroscopy. Was it normal or was there any abnormality in the hysteroscopy picture? It was not so clear.
Was normal. Now we see a fibroid. Please go ahead, sir.
Yeah. You take out this fibroid and do the laparoscopic encerclage also for this patient, because these are all mid-trimester abortions and we are not sure whether the abortions are caused by fibroid or cervical incompetence.
Can you please describe the procedure which is being shown on the screen? How would you approach this fibroid?
Yeah, laparoscopically, of course. Laparoscopically, there is no other way to approach such a fibroid.
Yes,
so it is better to do laparoscopy. And this is very close to the tube. So we have to avoid damaging the tube. That is one thing. So you have to take the incision away from the tube, and so that the suturing has to be done properly.
Absolutely, you can see the myoma screw. Can you describe the suturing?
Yeah, so suturing, normally we use barred suture nowadays. And of course, always preferably, this kind I would prefer in 2 layers because it is little deeper. So continuous with barb suture is good enough, and put an if the patient is affording, put an interseed over that so that it doesn't attract the adhesions.
Sir, how would you take the sutures? Can you describe? Is it from inside
So
out?
this kind of suture,
outside?
the best suture would be what we call baseball suturing, so that
Yes.
the baseball suturing, so that the overlapping of the sutures and the myoma bed will be better and hemostasis will be better.
So would you recommend ultrasound post-operatively?
Post-operatively, we will advise her not to conceive for 3 months so that the patient can wait for 3 months for conception. After 3 months, she can go for conception.
Sir, what do you recommend? In-bag morcellation or open morcellation?
Yeah, morcellation, of course, this looks like a benign fibroid. Only thing is you should not spill the fragments into the peritoneal cavity. So you do the thorough lavage at the end of the morcellation so that it doesn't give rise to parasitic fibroids. The other thing is if you are very suspicious, we do in-bag morcellation, or we can put a Eurosac and do the morcellation, or in-bag bags are available commercially. If the patient insists on in-bag morcellation, nowadays some patients ask for in-bag morcellation, so you put the bag and morcellate inside. But these kind of fibroids, I don't think in-bag morcellation is essential because it is looking like a benign fibroid.
Yes, sir. Dr. Kurian, please guide us on Dr. Ramesh's suggestion on this case. Kurian, sir.
Yeah.
Please unmute.
Yeah. I mean, first is, I don't know whether I would do a myomectomy for such a small fibroid. It looks a bit small. And it looks subserous, essentially, a little bit intramural. But once you've decided, you've done a good job, nice and clean, shelled out the myoma. The other thing is, when you're suturing, I don't know why you went inside out and got the edges everted up, because I'm not a big fan of doing that. So what I would do is, with a barb suture, I will suture one layer inside, and the second layer I will close the whole thing down with that itself. So with one length of barb suture, I'm putting 2 layers and I'm closing the whole thing completely. But I think
would you take the serosa separately, or would you take serosa separately? Is there any study?
Serosa goes with the muscle, definitely. You can't say taking the serosa separately. It's all, I mean, classical myoma suturing is thickness of the myoma as of the myometrium has to be included. Only then the myoma will, the wound will heal well. There's no question of trying to differentiate the serosa and all that.
Sir, second question is, if there are multiple fibroids which are there on the posterior wall, anterior wall, or there are seedling fibroids inside, so would you recommend a single incision for multiple fibroids, or we need to take different incisions? Because that is a common question being asked by most of the gynecologists, and we are talking about endoscopy for all.
I think we prefer to take multiple incisions. Suppose sometimes fibroid will be just below the fibroid. So those cases probably we can take out through the same incision. But by and large, if there are multiple fibroids, multiple incisions are better rather than single incision. Because if you try to remove through the single incision, so you are damaging a lot of myometrium and bleeding will be more.
Sir, last question. Dr. B. Ramesh, if inadvertently the uterine cavity opens, so what precautions would you take and how would you counsel this patient? And does it necessarily mean that when she conceives, she will have to go for a cesarean section?
If the cavity is open, there is nothing to be done. The cavity, the endometrium should not be sutured separately because it will attract adhesions. So you have to overlap the myometrium, you have to suture the myometrium over the endometrium so that the endometrium heals by itself. But the myometrium has to be approximated properly. And suppose if you have doubt And if this patient doesn't conceive within, of course, we will advise her not to conceive for 3 cycles or 3 months. Within reasonable period of time, if she doesn't conceive, I would like to do second look hysteroscopy to rule out formation of adhesion. So we can just do hysteroscopy to rule out adhesion. So otherwise, so we encourage her to conceive after 3 months. There is nothing to be done more.
Thank you. Thank you so much.
Niranjan, I have a small query.
Please, please. Yes.
I wouldn't, I'm sorry, I would beg to differ from Dr. Ramesh in doing a lab circlage for this patient.
Palyanappan, please say your name because I am not in the gallery mode. So
Dr.
I request
Palaniappan
please
from
raise
Chennai.
your hand and you can just, if I see, fine. If I can't, then please introduce your name so that
Fine.
then I can focus on your face.
Fine. So Palaniappan from Chennai. My only place where I would differ from Dr. Ramesh is that the myomectomy is questionable, as Kurian sir said, but I wouldn't do a lab circlage at that moment of time along with the myomectomy, because myoma could have been the cause for the previous abortions, but then there need not be a cervical incompetence because we have to wait and watch. And especially doing an abdominal circlage at that particular point of time along with myomectomy, we don't know how the uterus will shrink after the myomectomy, and then we don't know what will happen to the endometrium, what will happen to the cervix. So I would beg to differ that not to do a circlage at that point of time.
Now, because they are all mid-trimester abortions, so there is a possibility, high possibility that the patient may have cervical incompetence. So if you don't put the abdominal stitch, again the fourth one also she may abort. So there is no harm in putting the encerclage.
Sir, I am Dr. Priya Lakshmanan from Chennai.
Yes,
I
yes,
have a
yes.
doubt,
Yes,
sir.
Dr. Priya.
So this is a posterior wall myoma. Do you recommend any adhesion barrier, sir? Hello?
Yes, he has already said, Madam, Dr. Priya, sir has already said that he is going to use adhesion prevention barrier. I think his connection we have lost, but we have already said that we can use interseed. But if we use Sepra film, then we have to do a second look laparoscopy. And previously, when we were residents in 1990s, our seniors used to put ringer lactate and dextran 40 and dextran 70. But there were chances of anaphylactic reactions. And it basically, the idea was that, plasma, it gets absorbed in the plasma and it takes about 5 to 10 hours, or it might take in dextran few days. But then I think it was stopped because it doesn't have any other purpose. There were many studies which were done. And I think Dr. Palyanappan and even Kurian sir will agree with me that now it has got no importance and we just use barrier like adhesion prevention which are absorbable. Carboxymethyl cellulose has proved and has been the tested times that it can be usually used. Only thing is that it should not turn black. That means the hemostasis is not achieved properly. B. Ramesh, if I can take the privilege to answer you, if that is fine, you can add something and then we go ahead and move with the next question, sir.
Yeah.
Thank you. So we go with the next question now. And I call upon Dr. N. Palyanappan, OGSSI President, to please read his case. Thank you so much. Please unmute. Dr. Palyanappan, please unmute.
Miss LMN, a 24-year-old unmarried woman, has a history of pelvic pain since last 6 months. On ultrasound, she had a right adnexal mass of 4 by 3 centimeters diameter rising from the left ovary. It had a well-defined smooth border and a wall thickness of 4 mm. So the center of the mass showed a ground glass appearance and the patient was not willing for surgery.
Oh. Now usually she is unmarried. Palyanappan, sir.
Yeah.
And they are very skeptical and they don't want to get operated.
What
is your take on this?
I think I will think about doing.
What is your diagnosis, sir?
Of course, I'll think in terms of endometrioma of the ovary, and any more investigations, we might think in terms of doing a query MRI, maybe an MRI, not always necessary. And the patient requests us to avoid surgery. Yes, I would probably not put a surgery on an unmarried girl at the age of 24 for a 4 by 5 centimeter, probably if you confirm that it is an endometrioma. And the most effective medical management for her would be based on her symptoms, and pain is her only symptom at the moment. So I'll give her painkillers and then think in terms of putting OCPs like what Dr. Krishna Kumar and Dr. Kurian did mention. And I would probably think in terms of considering Dynegest at that point of time if she's not settling down with OCPs. And I would want to monitor her progress with medical management. Maybe after the next cycle itself, I'll want her to come back and see whether the cyst has come down by ultrasound or not. So that is how I would go on at the moment and not think in terms of a surgery.
Excellent discussion. Amazing. May I ask a quick response to Dr. Palyanappan's response from Dr. Ramani Devi? A quick response, please.
Sir, I think it is being an adolescent girl, it is always better to avoid surgery, like Palyanappan has already mentioned. So the drug of choice is one is either a oral contraceptive pill or a Dynegest. Preferably at this scenario, if she can afford, I would rather prefer a Dynegest drug because it can act at all levels of the endometriosis. For example, it can act as an anti-inflammatory agent, anti-proliferative, and so many other things. It has got specific for, it's a progesterone that is specific for endometriosis. So my choice will be this. But before that, it is apart from an ultrasonogram where it done by a good person, it can give you the exact diagnosis. There should be no difficulty in diagnosing endometrioma by a simple 2D ultrasonogram. If necessary, maybe if she can afford, MRI will give us a better imaging, better accuracy of the disease. Because at this age, we have to rule out other germ cell tumors also in this particular patient. So that has to be differentiated. And in that case, you can get the help of the MRI.
Madam, now I would like also to ask Dr. Sampath Kumari, are you there? Madam, most of these girls are coming with severe pain, and that pain always is there every time. It doesn't just go, it is in between the period, during the period it's excruciating, they cannot do the normal. And I was told yesterday when we were along with Dr. Sanjay Patel in Gujarat, he is also a very good endometriotic surgeon, especially during the rectovaginal plate. He says that out of 100, 1 or 2 girls even have suicidal tendencies. Such bad endometriosis is there. So I want Dr. Sampath Kumari's and Dr. Jayam Kanan's, experience on this. Such girls who come, they might be even at, madam, this is a 24-year, but there are girls of 16 and 18 years also coming.
Correct.
As far as possible, to my knowledge, for adolescent, there is no need for surgery. As madam told, you can go with the progesterone groups or Dynegest. Medical management, and then we should ask her to divert her mind and get interested in whatever work she is doing. The mild pain, if you are going to go for a surgery, means it will be as previous speakers, everyone told, the first surgery should be a good surgery. Yes. So as far as possible, the medical management, Dynegest or progesterone injection or whatever it is, medical management will be better.
Dr.
I definitely go with Dr. Ramani and Sampath Kumari. In adolescent, we should be less inclined to do any surgical interference.
Very important point, take home message, very important point.
Yes.
That's why we have got senior ladies who have worked in adolescent committee, and we have got Ramani Devi who is in endometriosis. Asha Rao madam is also there. And thank you, Palyanappan, for that wonderful discussion which you started. Jaya madam, please continue.
But any endometrioma will not be showing any reduction however long the Dynegest has been used. 52 months of Dynegest in adolescent has been worked with the Vicene product, but they were able to control the pain 98%. Cyst remained the same. So we have to drill in mind the adolescent that don't worry about the cyst. It is like a pimple in your abdomen, but get relieved of your pain. That is a message I would like to give for adolescent endometriosis.
Ramani Devi madam, your take, and then I go to Asha Rao, the chairperson of Endometriosis committee.
Okay.
Dr. Ramani Devi, your take on this.
Yeah, the thing
You
is,
wanted to say something.
Patients cannot afford for dynages. I think even we can go for simple Depo-Provera. That is also very useful drug, which has got a very good pain relief. But of course, it has got its own side effect of reduction in bone mineral density if you are going to continue for a longer time. So we can suggest also any sort of progesterone will be of use. So the take-home message is don't do surgery, only medical management. Unless the indication for surgery is pain not responding to your medical management, or if there is suspicious of malignancy, or you don't think that even 1/3 of the patients with adolescent group, they have deeply infiltrative lesion. So this may not respond to, sometimes it may not respond to our medical management, and there is a last chance and the least chance the patient may be subjected for surgical management by expert hands.
Thank you. The audience has been posting some fantastic comments and suggestions, and I'm glad to announce that we have more than 1,230 doctors who are seeing us live. It's amazing. I want to ask our chairperson of Endometriosis Committee, Dr. Asha Rao, do you add antidepressants in some cases who are having these issues about an endometrioma? You are giving them medical line of treatment, but they are not able to function the normal life. Just a thought came in my mind because there are certain girls who cannot handle the situation. So what is your take on that, madam? Quick one-liner.
Yes. Sometimes there are occasions where they may have to be given antidepressants. Yes. Because of the pain factor.
Yes,
because of the excruciating pain. The pain is to that extent that they might be needing antidepressants.
Absolutely, I agree. Thank you so much, Dr. Palyanappan. And it's very nice discussion which we have got through all such situation of a girl. Now I call upon our next presenter, Dr. Sharmila Ayo. Please go ahead.
So the slides are not moving.
Yes.
She's a 34-year-old, AMH is 1.8, and she comes with a history of infertility. Ultrasound shows a 4 centimeter endometrioma. She's already undergone 3 IUI cycles which have failed. Now she wishes to conceive. All hormonal tests normal. The husband's semen analysis shows mild oligospermia. So her age factor of 34 and an AMH of 1.8 tells me that she's got a lower ovarian reserve already. She's undergone infertility treatment and 3 IUI cycles she has failed with a mild oligospermia. So my treatment will be going for IVF. Suppose I've got a good access to the other ovary and this endometrium of 4 centimeters is not interfering with the ovum pickup. So I will do a proper ultrasound, map out the uterus as well as the ovary before I decide for an IVF. But IVF will be a much better option than any other procedure because of her low ovarian reserve now. And the other thing is she is not having any pain. So that pain factor is not there. So I don't think that there will be, other than endometrioma, she may be having just mild adhesions because pain factor is not there. Age factor is against going for any other procedure like surgery at the first shot because she's already 34 years of age. And a male factor is also not normal. It's a mild oligospermia. So just doing a laparoscopy and asking her to wait for a normal conception or with IUI may not work out because she's already failed an IUI.
Okay, I would like to have a quick response. Sorry, sir. Please go ahead.
Yeah, I have a question here. The 4 centimeter endometrioma, will it not interfere with the follicular development?
So that's what the study which Dr. Kurian Joseph sir put up, as well as Dr. Krishna Kumar, saying just having an endometrioma may not interfere with the oocyte development, and you can get enough oocytes even if there's an endometrioma, because you've got the other ovary which is normal. And if this endometrioma is not in the way of your ovum pickup and you're avoiding that, you will not even go for an infection. That's what we are scared of when you're having an endometrioma, about ovarian abscess. But because already our AMH is 1.8, I would rather go for IVF rather than laparoscopy, because she may be losing more oocytes if I go for an laparoscopy and then for an IVF. That's
we will come to Dr. Ramesh. We will come to Dr. Ramesh. Fantastic, Dr. Charmila. I want to have opinion of Dr. Kurian sir on the response of Dr. Charmila, and then I will come to Dr. Ramesh.
Well, I agree with her. I don't think we have much choice. One will have to, whatever is available with us, we have to adjust with that. You can't say that I will not do this or will not do that. So I agree with her. Okay.
Thank you, sir.
Dr. Ramesh, your take, and then we move on to the next question. I would also like some comments from Dr. Priya Lakshmanan. She is also an IVF consultant and she is an endoscopic surgeon. Dr. Priya, please, I request all of you to please open your videos. We have got a transmission which is superb. You will not have any interference.
Sir, I would also like to support Charmila ma'am on her management, because doing a surgery on this patient is further going to compromise the ovarian reserve on these patients. So it's better to take up these patients on the first go for an IVF. And since this patient has also got a male factor.
Today, I will not lose any opportunity to hear from you as much as what the nation wants to know. So I request you please open your videos and be there. And it is a wonderfully going on, more than 1,200. Dr. Jayarani Kamraj, I can see you smiling. I want your opinion and then we go to the next case. Thank you.
So I too agree, as a specialist, as an infertility specialist, we also agree that being her age, about the previous failed IUI cycles and every other parameter showing the lower reserve, it's best to resort to an IVF, of course, because definitely she don't have any other symptoms of pain or anything related to the endometrioma. So her only concern is the fertility. So it's best to go for a IVF for her. The only thing, as she rightly said, that we have to avoid this endometrioma when you are doing the oocyte pickup. We have to have a little more careful about doing that. We will prefer to do the normal ovary first and go as the last thing to that ovary.
And have those pick up at the last, and the eggs also separated from each other. So there's no contamination of it.
You know what? I'm so lucky today. I'm the only guy who has come from West India, Mumbai. And I'm so happy that I'm meeting all of you. And it's like galaxies who have come down on Earth. And it's amazing that we have the seniors, the middle and the younger generation being a part of this elusive endometriosis and fumbling fibroids. And I'm sure now the fibroids are shaking and they are trembling because we have fumbled them and we have removed them. So Dr. Kurian, I'm very happy to see you here today, and he is the teacher of teachers. Dr. Jayam wants to say something. Yeah. Madam, please.
Yeah, with 3 decades of experience in ORT, I would like to say, when you are stimulating the ovaries, the endometrioma will not expand in size. Number 1. Number 2, by a chance that you have picked up, punctured the endometriosis cyst, remove it in the tubes, discard the tubes, change the needle, and proceed with the further oocyte pickup, so that the subsequent oocyte qualities are not altered by the prostaglandin effect, which can be there in the tube, which can damage the oocytes. These are 2 points which I would like to give for the younger generation.
Thank you so much. Thank you. Now we go ahead with the next case. Dr. Damodar Rao, I welcome Dr. Damodar Rao. Please go ahead.
Yes, sir. This is a 28-year-old infertile patient, married since 2 years, presented with intense pain in the hypogastric region and left iliac fossa for 7 days. Her history, she has chronic pelvic pain related to the menstrual period for 1 year, with worsening of symptoms in the last 4 months. Physical examination, normal vital signs, no fever, flat abdomen, presence of bowel sounds, pain at deep palpation of the hypogastrium and left iliac fossa, and absence of peritoneal signs. Vaginal examination reveals retroverted uterus, fibroelastic colon, intense pain at uterine mobilization, and at palpation of posterior and left lateral cul-de-sac, left adnexal mass palpable, tenderness present, size approximately 5 into 6 centimeters in size, felt separate from the uterus. And pelvic ultrasound reveals normal size of the uterus with small quantity of free fluid in the uterine cavity, and left adnexal endometrioma measuring about 5 into 6 centimeters. So this is a case of a chocolate cyst of 5 into 6 centimeters, and she's a 28-year-old, married for 2 years, and she has intense pain too. So I think this lady is probably a suitable candidate for surgery. But one thing I would like to know is her AMH. Her
AMH is normal.
AMH is normal. Then I think this is probably one of the few situations where we can think of doing a surgery for this lady instead of giving her a medical line because of the presence of intense pain. That is probably one of the major indications for surgery.
Oh, what will be the role of Dynogest, GnRH and progesterone?
There's any role for Dynogest or GnRH in this particular case because it's a case of infertility also. The best thing to do for her would be to give her a surgery, relieve her of her pain, and do a good cystectomy, and that itself might give her a good pregnancy.
So after surgery, do you plan to give her any medical line of treatment?
There is no role for medical management after any endometriosis surgery if the patient is for infertility. We do not give any medical management, sir. The best time to become pregnant is soon after surgery.
Yeah, so can you just give us some tips and tricks for this ovarian surgery, which the viewers are seeing it? And excellent voice you have, Dr. Damodar. Your patients will surely feel very good hearing you. I thought such comments are also important to a doctor. Don't you feel so for Damodar?
Thank you, sir. So this is basically the left endometriotic cyst that you're seeing. Always there are different ways to tackle the cyst. Either you can just try and peel off the cyst wall first, but many a time while doing this, the ovary will give way at the punctum and the chocolate fluid will come out. And then what you do is raise the ovary out of the ovarian fossa, and then you start doing your cystectomy. If you want to inject vasopressin, you can. Or if you want to inject vasopressin into the uterus also, you can. This is a beautiful case where the chocolate cyst is coming out beautifully, but we're not gifted with such chocolate cysts all the time. So we have to be very, very meticulous in, dissecting out a chocolate cyst. However good, even the best surgeons in the world cannot, there will be some loss in AMH. So we have to counsel the patient about all this while, doing such a surgery. And of course, about this particular surgery, meticulous traction, counter traction is very important. Go near the place where you have peeled out. Don't just hold the two edges and try and yank out the whole thing like that. You have to do a good traction, counter traction and meticulous surgery. And at the end, if there is any bleeding, what you have to do is only do a pinpoint coagulation. Don't try and coagulate the whole thing. Many a time, don't even, just give a good wash. Look at everything else that's happening. By the time you come back, you will see that a lot of the bleeding has stopped on its own.
Dr. Kurian, sir, I want your special comments on this. Maybe you can add something more. Sir, please unmute.
The important point is the three instruments are being used. And with that, you're using toothed forceps to hold the tissue properly. Because very often people use just the ordinary Maryland forceps that doesn't grip. And in the process, you will tear the ovary more. And only thing is, there's a certain amount of charring of the tissue which really not necessary. One could have been with less electrosurgery at that time. Because if you see any brown thing means the tissue has been burnt. And what one should do at that situation is if it is oozing, just keep some pressure for some time. You'll find the whole thing stopping and then proceed with surgery. So you will see that we hardly use any bipolar inside. It's not needed normally. You either roll the ovary or you just keep both edges of the ovary together, keep some pressure and distract yourself doing something else. I would tell my assistant to pour fluid and wash the peritoneal cavity at that time. And after some time when you see, you will find everything nice and clear. The other method is possibly tell them to test the tubes at that time. When you finish testing the tubes and come back, the bleeding would have stopped. So that's it.
Wonderful, Dr. Damodar. We have got excellent pearls of wisdom by Dr. Kurian Joseph, and I find you all giving your ideas and the takes. So there are a lot of questions, a lot of comments are there. They are very, very happy to hear and see you since we are not meeting in person. I am very thankful that all of you have accepted this invitation, and Times of Gynecology Science Integra has been doing a wonderful job. We have done more than 100 webinars by now, and I want to tell you that each one of you have given your valuable time today in spite of your busy schedule and in spite of you being very busy, not only in your patient's management, but also at home, because now we are not only as Corona warriors, but we are also at our home with our better halves. We have to face those warriors also. So, and there are two or one more warrior which are small. So all these warriors becoming Corona pandemic, and Palyanappan is smiling, Damodar Rao is smiling, and I find so many smiles on your face. With this, I would like to end our webinar. We had a wonderful time. Thank you, madam, so much. And I want just one-liners from each one of you, and then we will end the show. Thank you. Just one-liner on endometriosis and fumbling fibroids. I start with Dr. Kurian, sir.
Thank you, Niranjan. It was good. I think with endometriosis, one has to be careful. No playing the fool. If you think you can't do it, don't do it. Get somebody else to do it. Thank you.
Dr. Ramesh.
Yeah, I think endometriosis we should move from surgery to medical line of treatment more. You know, as we experience more and more, we see that the surgery many times does harm rather than doing good to the patient. So the recent trend should be, in the future, the trend should be avoid surgical treatment, move towards medical treatment. That doesn't mean you don't stop doing surgeries for endometriosis. For example, the rectovaginal endometriosis needs surgery irrespective of the thing. So that is my message. Go more towards ERT and more towards medical line of treatment.
Thank you. Dr. Jayam.
Yeah, endometriosis surgery has to be patiently planned. Do not look at the time of anesthesia. Do not use more of thermal care. Go back to 1990s where we used to just keep compressed and watchful expectancy till the bleeding is restored, completed. So that at that time we did not have AMH, but we had the ovaries showing the response which was there prior to surgery. So please keep away all your thermal care instruments when you are doing a endometriosis endoscopic surgery.
Dr. Ramani Devi.
Yeah. I think rightly Dr. Ramesh has discussed that there should be a shift more towards medical management. But that doesn't mean that surgery has to be condemned. It has to be chosen for a proper patient. Case selection should be there proper assessment of the anti-ovarian hormone, especially in patients who are waiting for infertility, and then you have to go in for a detailed counseling before you are doing the surgery, because the surgery is not without complication, and to be done in a center of excellence for endometriosis. And in patients who have completed the family, I think if there is a unilateral presence of endometria, you can go ahead with that surgery, and you need to take all precautions for prevention of recurrence. That is going to be a real menace in this situation.
Thank you. Dr. Sampath.
Good evening, Niranjan.
Yes,
You
madam.
have become a good comparer with this webinar program. So whether it is fibroid or endometriosis, avoid surgery at least in adolescence. That's all.
Thank you. Thank you, Dr. Asha Rao.
Yeah. Yes, Dr. Niranjan, it was a wonderful webinar and you have brought out the points so beautifully. And I would like to stress that since endometriosis is a lifelong problem, we should definitely try to reduce the number of surgeries and a rational treatment, right treatment at the right moment, minimal surgery, and try to manage it medically as much as possible unless infertility is the problem. Yeah. Thank you.
Dr. Priya Lakshmanan.
Oh, yes, sir. Thank you so much for the opportunity that you made an elusive endometriosis more approachable and a fumbling fibroid more manageable, sir. And the point I would like to say is both medical and surgical managements have become very standardized right now. So following the right protocol will give the best for our patients, because at the end, what is more important is the quality of her life. Thank you so much.
Thank you. Dr. Jayarani Kamaraj, madam.
So I would like, thank you, Dr. Niranjan, for this nice webinar. I would like to stress individualization, as rightly pointed out by the doyens, are very important. You have to take into account of the patient's symptoms, her need, her quality of life. Everything has to be looked up when you plan the treatment. It may be surgical or medical, but you have to individualize the patient's need and the care, which is very important as a clinician that we have to do. And secondly, very important is you have to look at the quality of life in respect to the endometriosis. And as the doyens are here, we have to look into a preventive aspect of endometriosis, which is also very important to make the women get away from this endometriosis at the earliest.
Thank you. Dr. Palyanappan.
After listening to this webinar, it's been fantastic, and you ordered only one line. So let me put my one-line tagline and say, from fabulous fibroids, it's become fantastic fibroids, because it's been improving the surgical skill of every endoscopic surgeon. And from elusive endometriosis, let me word it as efficient endometriosis, because it makes you and me more efficient than what it was before. Thank you very much for this wonderful webinar, and all the best, Niranjan, for all your future endeavors.
Thank you. Dr. Charmila, madam.
So you were asking something on ultrasound during fibroid surgery. Actually, there should be a proper mapping of your fibroids before you take off a surgery, because you can miss certain fibroids when you do it through a laparoscope. So map your fibroids, particularly the ones which are protruding into the submucous area. That should be totally mapped out. And the other thing regarding endometriosis, if you need to, you go for MRI, go for that also, because you need to do everything pre-operatively before you go into a surgery, because it, as everybody said, it should be a pakka surgery and it should be done at the first shot. You cannot keep on doing surgeries for her without a proper assessment, because that's going to damage a career, a reproductive career, which is a great problem in an Indian woman. That should never be done.
Yes. Dr. Damodar.
Niranjan sir, thank you. Thank you for this wonderful opportunity. Great webinar as usual, like all your other webinars. Regarding endometriosis, I think like all the stalwarts have said, medical management is the first choice. As much as possible, stick to medical management. But if the patient requires surgery, please remember the first surgery should be her best surgery. Thank you.
Thank you. Thank you. So I bow down to all the seniors here and bless us to do better. My pranams to all. And I would like all the viewers, thank them from the bottom of my heart that it was wonderful time you spent with us. And that's what is Times of Gynecology. We bring you the best of all and the best scientific discussion with contents. And I thank each one of you to be a part of this journey. And I hope Corona goes away very soon. And kindly be safe. Take care. Be strong. And see you soon.